Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network and the Lineberger Comprehensive Cancer Center. Thank you so much for being with us today for the UNC Cancer Network Medical and Surgical Oncology Lecture. Let's see, a few details before we get started and introduce our presenter today. If you are having any technical difficulties, you may email us at unccn@unc.edu. You can call or text us at 919-445-1000. We're going to use Poll Everywhere for our questions and for a poll at the beginning, and I'll go over that in just a moment. You can find us on the web at unccn.org and find us on Facebook and Twitter as well. All right, the poll we're presenting today, what is the percentage range for the local recurrence rate in patients treated for rectal cancer? Now, you can put A, 5 to 10%, B, 10 to 20%, C, 20 to 30%, or D, 30 to 40%, and then we'll answer that question in just a couple of minutes. The way you use Poll Everywhere, both to get started at the beginning and then for the Q&A at the end of the presentation, is you text the letters UNCCN to the number 22333. So 22333 you'll put in as the number you're texting to with the letters UNCCN. That will join you to the Poll Everywhere session for today. You only need to do that once, and then after you do that, you can go ahead and send the answer to the first question. Again, A, 5 to 10%, B, 10 to 20%, C, 20 to 30%, or D, 30 to 40%. So if you would, go ahead and join Poll Everywhere, and then go ahead and text us what you think the answer is, and then we'll go over that in a moment. We do have a disclosure statement today. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director, in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. The speaker, Dr. Karen Stitzenberg, does not have any relevant financial relationships with commercial interests. Dr. Karen Stitzenberg is an associate professor in the Department of Surgery within the Division of Oncology and Endocrinology Surgery at the University of North Carolina, Chapel Hill. She is also a member of the Lineberger Comprehensive Cancer Center. A majority of Dr. Stitzenberg's clinical practice focuses on caring for patients with lower GI and skin malignancies. Dr. Stitzenberg is a 2016 recipient of the UNC Healthcare and Faculty Physicians Award for Carolina Care Excellence. All right, Dr. Stitzenberg, welcome. Thank you so much for being here today. Let's take a look at this poll and see what we come up with. All right, we're good. We've got lots of participation today. Thank you to all of our audience members out there for jumping right in and answering this poll. We'll give them a few more seconds. Did you want to comment on the correct answer for this?
Yeah, I think it's a little bit hard number to pin down, and in fact our most recent response is evened out. I think we had intended the answer to be B, but you could argue C. It depends a little bit on what data you're looking at. Certainly clinical trial data will lead you to believe that the recurrence rate is probably somewhere closer to the 10% range, but in practice nationwide it is probably much more like 20 and may creep above 20. So B or C is in the ballpark for local recurrence, which I think the important factor being that that's a lot higher than many other malignancies in which distant failure is really our bigger problem, but that rectal cancer has a high rate of local recurrence that is a challenge.
All right. Well, thank you so much, and it does look like most of our audience did well with this. With that, let's go on to promising new treatment options for rectal cancer. I'll pass the controls over to you.
Thank you.
And you've got the mouse with the cursor if you need that as well.
So I wanted to talk this morning about treatment options for rectal cancer. Rectal cancer is a disease in which there is a whole lot of investigation going on right now. Not so much into systemic therapies like you might find in other cancers where there's the new latest and greatest chemotherapy, but actually just in terms of how do we sequence treatments, how do we get done what we already know works and deliver it the best. And because there are a lot of new treatment paradigms out there, there is some confusion about what is the standard of care and what is still investigational and how best to manage patients. And so for the first part of this, I'm just going to review rectal cancer and what is currently the standard of care. And then I'll talk about some of the new treatment paradigms and how close those are to prime time or not. So as a review, rectal cancer is associated with high rates of local recurrence. As a result, for the majority of rectal cancers, the best treatment involves trimodality therapy. What I mean by trimodality therapy is a combination of surgery, radiation, and chemotherapy to be delivered as a treatment course as the standard of care. This trimodality therapy really is aimed at minimizing the risk of recurrence and optimizing oncologic results for the cancer. However, trimodality therapy is complex and also carries substantial morbidity. And so as a result, many have sought to find alternative treatment approaches that can minimize the morbidity. Really trying to examine, are we possibly over-treating rectal cancer, or can we in any way simplify care? Recurrence rates, like we talked about earlier, are somewhere in the 10-20% range. For higher risk rectal cancers, it might even be a little bit higher than that. But with modern high-quality treatment, it should be somewhere in the 10-20% range. The morbidity is high, as I mentioned, and morbidity can lead to decreased overall survival. It may also mean that cancers aren't resectable. So this is actually the morbidity of the recurrence. If you have a recurrence, a local recurrence, you can have decreased overall survival. That local recurrence also may no longer be amenable to surgical treatment, which by definition means it will be not curable. And that local recurrence, if it is resectable, often requires multivisceral resection, meaning that in women, often part of the vagina or the uterus may have to be removed in order to remove the recurrence, or in men and in some women, the bladder may also have to be removed. It is also not uncommon for us to have to remove sacrum to eradicate a local recurrence. And so the surgical treatment of local recurrences mandates much more aggressive treatment than generally first-line surgery. So addressing local recurrences, trying to prevent them, is important for all of these reasons, both overall survival but also quality of life. So the treatment itself is also associated with morbidity. For the radiation that patients receive, pelvic radiation, they can experience altered bowel function due to radiation injury to the rectum or to the small bowel. The radiation can lead down the road to bowel obstructions from adhesive disease. Radiation can cause sexual dysfunction, both infertility, but also impotence and other problems with dyspareunia and other problems with sexual function. And lastly, radiation can cause bladder dysfunction. In most people, the bladder dysfunction and the bowel dysfunction will improve after treatment and may go away entirely, but some of that may be lifelong as well. The bowel complications of the radiation have been minimized as we have moved radiation to be delivered prior to surgery. So now, which I'll get into a little bit, in general, the standard paradigms involve giving radiation prior to surgery and then surgery. And what that does is that the damage, if you will, that the radiation is causing to the normal rectum is then removed with surgery. And so then when you do your reconnection or restore GI continuity, the radiated bowel has been removed. If you do the surgery first, then the bowel that ends up being radiated is something that will stay with the patient for a lifetime. And so that radiation damage will continue to cause problems down the road. So this is one way that we have successfully minimized some of the morbidity, but it is just a small piece of the side effects that patients have after having rectal cancer. Surgery also has a lot of morbidity. One is the altered bowel function. So when patients have their entire rectum removed, then they will have a permanent ostomy, and that obviously is an alteration in quality of life. And if patients have part of their rectum removed and are able to have GI continuity restored, they will never have the same bowel function that they experienced for the majority of life. At best, patients may get to something very tolerable that just becomes their new norm. And at worst, the bowel function can be so bad that patients actually elect for an ostomy. And this is the result of interruption of some of the reflexes that are required for defecation, and also not having the rectum for capacity. And so patients commonly experience difficulties with what's called cluster bowel movements, where they may evacuate and think that they're done, and 10 minutes later have to go to the bathroom and go more, and they may have to go every 10 to 15 minutes for an hour to an hour and a half, after which time they will be done, but that happens every time they have to have a bowel movement, and that can be very detrimental to quality of life. Surgery also can impact sexual dysfunction. The hypogastric nerves that innervate the rectum also innervate both the bladder and the sexual organs, and so retrograde ejaculation in men and other sexual dysfunction in both men and women is common. And lastly, perineal wound healing problems. For patients who do have their entire rectum removed, it can be a challenge to get the wound on their bottom to heal, and that can become a source of morbidity as well. The chemotherapy for rectal cancer is actually relatively gentle on the scale of chemotherapies, and probably the most common complaint of morbidity is peripheral neuropathy that comes with the oxaliplatin treatment. But other than that, long-term morbidity from colorectal cancer chemotherapy is relatively minimal, particularly in comparison to the surgery and radiation. So reviewing standard of care treatments. I'm going to break the stages of rectal cancer down based on how we treat them. The first group is the stage 1 tumors. These are T1 or T2 tumors with no nodes and no distant mets. And at the bottom here, I just have a review of how we stage rectal cancer. Colon and rectal cancer are not staged by the size of the tumor, but rather by how deep the tumor invades into the bowel wall. And so a T1 or T tumor is relatively favorable. And actually within stage 1, we break the treatment down into the earliest, most favorable tumors, and then the rest is stage 1, and I'll get to that in a minute. Stage 2 and 3 are grouped together because those are treated the same. So once the tumor invades through the muscularis propria into the subserosa or beyond, or the patient has evidence of nodal involvement, then they get a different treatment paradigm. And the last group is the stage 4. These are patients with distant metastases. I'm actually not going to talk about treatment for distant metastatic disease today. I'm going to focus on the non-metastatic cancers. So for the earliest group, what I call the favorable stage 1A tumors, these are patients who just have, go back here, submucosal involvement. In addition to that, the tumor involves less than 30% of the circumference of the rectum. The tumors are well to moderately differentiated, and there's no evidence of lymphovascular invasion. So these are truly your very early tumors. They're also quite uncommon. There aren't a lot of patients whose cancers are caught at this stage, but if they are, then these patients are eligible for what we call a transanal excision. And what that means is the goal is just to remove the tumor itself, not trying to take out any lymph nodes or anything else. And we're able to do this with an operation that's performed through the anus. We remove the tumor and a margin of normal bowel wall around the tumor, and then close that hole in the bowel wall of the rectum. From a side effect standpoint, it's very low morbidity. Patients tolerate this quite well. It's really sort of the ideal treatment if that's all the treatment that you need for your rectal cancer. But again, very few patients are actually eligible for this based on these criteria. I threw some other acronyms up here that are newer surgical approaches. One is TAMIS, one is TEMS. What these both are basically are newer advanced ways to perform a transanal local excision. Classically, transanal excision was performed just with a speculum in the rectum, and the surgeon did the surgery with their hands. TAMIS and TEMS, in essence, are the endoscopic or laparoscopic versions of transanal excision. Instruments are used just like would be used for laparoscopic surgery, but they're used transanally. And what TAMIS and TEMS do is they allow local excision to be performed further up, more proximally into the rectum and even the distal sigmoid colon than would have been able to be done in the past. So all other stage 1 tumors, meaning T1A and T2 tumors that don't have the favorable characteristics, are best treated with what we call total mesorectal excision, or TME. What TME is removal of the relevant portion of the rectum along with all of the lymph nodes in the mesorectum adjacent to the rectum. TME can be done really as 2 different operations. One is called a low anterior resection, and one is the APR, or the abdominal perineal resection. I think all these acronyms get confused, so just to clarify that, both of them are types of TME. The difference is, in a low anterior resection, only part of the rectum is removed, and then the bowel is generally reconnected. Although these patients do often require a temporary diverting ostomy, it does not require permanent ostomy. In contrast, an APR involves removal of the entire rectum and the anus, including the sphincters, and so the only option is for permanent colostomy in these patients. While you could reconnect them without the sphincter muscles, they would be incontinent, and certainly an ostomy is preferable over a diaper, and so these patients do get a permanent ostomy. Which one you get really just depends on where the tumor is within the rectum. Well, I should say that it's dependent on where the tumor is within the rectum, but also on the patient's sphincter function, quality of life, and goals, because a very low anterior resection can have extremely altered bowel function, and as we talked about earlier, for some patients, that's actually a worse quality of life than an ostomy. And so some patients, for example, those who already have difficulty with some mild incontinence, may be better served with an APR than an LAR. All right, on to stage 2 and 3. For these, which is the most common rectal cancers, are stage 2 and 3 rectal cancers, we do the standard trimodality therapy. Patients receive roughly 6 weeks of neoadjuvant radiation. This is given with oral or infusional 5-FU as a chemosensitizer. It's followed about anywhere from 4 to 16 weeks later with a TME surgery, either an LAR or an APR. And then finally, afterwards, after patients recover from surgery, they will receive a full FOX regimen, either 3 to 6 months, roughly, based somewhat on their past stage, somewhat on what treatment they got prior to surgery. So, as I mentioned, there are a lot of new strategies out there. And the aims of the strategies come from 2 places, really. One is surgical innovation that has come about with a goal of decreasing surgical morbidity. And then the other is a goal to try to tailor the trimodality paradigm in order to avoid overtreatment. So examples of surgery innovation, I mentioned the TEMS and TAMIS and being able to minimally invasively, if you will, do a local excision in the rectum. That saves the patient having to have an upper abdominal incision. Other examples of surgical innovation are laparoscopic and robotic TME. I'm not going to cover the data for those today, but suffice it to say that studies would suggest that TME can be safely performed laparoscopically or robotically, and as long as the tissue that is removed is the same tissue that you would have done open, that it is equivalent to an open TME procedure. And so those are accepted ways to perform rectal cancer resections. So one of the innovations that's been tried is to do transanal excision for more advanced tumors. Let's not just treat the very early tumors with transanal excision, but can't we push this to include all of the T1 tumors or even the T2 tumors? Well, the data would say that we can't safely do that. Local excision alone is inferior for oncologic control of most rectal cancers other than those very early T1 tumors. Well, why is this? If you remove the whole tumor with a margin, what's the difference between doing a local excision and doing TME? And it's really the occult nodal disease. So even the patient who has the best MRI, the best endorectal ultrasound, and there's no evidence of lymph node disease on either of those, for patients with T1 tumors, up to 10% of them will actually have lymph node metastases found at the time of surgery. And for T2 tumors, that number can be over 50% of patients will have occult metastases that aren't detectable any other way than removing the lymph node and looking at it under a microscope. And so because of that, since transanal excision alone doesn't actually remove any lymph nodes, it's an inadequate treatment for those patients. One approach to trying to treat that occult nodal disease without doing TME was to add chemoradiation to local excision. And this has been tried, and there continue to be some studies looking at this, where patients get neoadjuvant therapy first with chemoradiation and then have a local excision of the tumor. Unfortunately, the rates of recurrence for patients who have residual tumor after chemoradiation are quite high. And so, in other words, if you have chemoradiation and then you have no evidence of tumor left at the time of your local excision, then your local recurrence rate is quite low, 4%. However, if you have chemoradiation and then a transanal excision and there's any tumor at all left in the rectum after the chemoradiation, then the local recurrence rates are roughly 1 out of 4. In addition, the chemo and radiation increases the complication rates of the transanal excision, where about 1 out of 4 patients will have a complication, and 1 in 10 will have complete breakdown of the area where the tumor was removed. And so there's not a lot of excitement right now for local excision alone after chemoradiation, except in patients who've had a complete response. And I'll talk a little bit more about those patients when I get to talking about what we call non-operative therapy. Despite this, we did a study looking at the use or misuse of transanal excision. And what we have found is that even though the indications for transanal excision have not broadened, transanal excision is increasing as a treatment in practice. In other words, patients who really, by standard of care therapy, don't meet criteria for a transanal excision are getting transanal excisions, and this is being inappropriately applied in practice. Patients that are at highest risk of getting a transanal excision, even though they, by clinical criteria, that isn't the standard of care, are older patients, those of Black race, and those who are uninsured. The older patients is maybe not quite as concerning because this may include patients who really just weren't fit for a larger operation, and possibly transanal excision was just performed to control bleeding or get a diagnosis, and the patients were not getting curative intent surgery. But the other disparities are certainly alarming. And you'll see from these figures, you said I had a pointer here. This blue line, this yellow line are the people that, the blue line and the yellow line are the people that we think are probably appropriate candidates for transanal excision. But the gray line is people who had poorly differentiated tumors, so they did not meet those criteria. And the red line are patients that had T2 tumors. So even though they really shouldn't be getting a transanal excision, the percentage of patients getting transanal excisions is increasing. And this is concerning, and it's something that's being looked at as to why this is happening. Moving on to a different surgical innovation, there is a very early move for what's called TATME, T-A-T-M-E, or transanal TME. And this is a small group of surgical innovators who are working to perform total mesorectal excision transanally. And so there would be no abdominal operation. This would all be done from the anus, but you would remove the entire rectum and all of the lymph nodes. The advantage of this is certainly that it spares an abdominal incision. However, the morbidity of the operation in terms of altered bowel function, risk of sexual dysfunction, and some of the wound healing complications still remain. So even though there's no abdominal incision, this is still TME with many of the downsides of TME. Early studies showed that there are similar short and long-term outcomes as compared to laparoscopic and robotic TME, as could be expected. But it's important to know that less than 1,000 cases have been done worldwide. This is only offered in a very few centers. And it's not something that's going to be able to be studied on trial because there are so few people that are going to be doing this. And so I applaud both the UK and the US. Two groups have developed registries in order to enroll these patients in a registry so that we can track the outcomes for these patients. But it is sort of the next step, the new frontier in surgical innovation for rectal cancer. Moving on to changes in the treatment paradigm, one thing that has been tried is short course radiation. There are 3 trials that have compared short course radiation therapy with long course radiation therapy. So instead of 50-40 gray delivered over about 6 weeks, these patients get just 5 treatments of 5 gray, followed by immediate or delayed surgery. There appear to be no differences in local recurrence or overall survival, and actually these patients had lower acute toxicity from the radiation and no differences in late toxicity. And so this is a promising approach, but it has not been largely adopted at this point. The standard still is the longer course radiation is what's being done at most institutions. I think that we will see more of the short course moving forward, but time will tell. This is probably one of the 2 most controversial proposed new algorithms, and that is omission of radiation. Some people argue that the radiation is really, in the past, the benefit of the radiation was to make up for poor surgery, and now that we're doing better, more comprehensive surgery, maybe patients don't need the radiation for their rectal cancer, particularly the earlier rectal cancers, the ones that have very limited nodal disease or just early penetration through the muscularis propria. And so if we can omit pelvic radiation, we avoid the enteritis, sexual dysfunction, delayed bowel obstructions that come with the radiation. And there is an ongoing randomized control trial looking at this. There was a pilot study done at Memorial Sloan Kettering. It was a randomized control trial. It only involved 32 patients. And they received FOLFOX and bevacizumab followed by TME surgery. What they found is that 25% of patients had a complete pathologic response to the neoadjuvant therapy, and so when the TME was performed, the tumor was completely gone. And they've had no local recurrences from this study at 4 years. Those data were very promising, and so the PROSPECT trial is currently enrolling. They've dropped the bevacizumab because the bevacizumab carried substantial toxicity and probably not any benefit. And so it's neoadjuvant FOLFOX followed by TME surgery. Accrual is ongoing, but accrual has been slow. Probably been slow for 2 reasons. One, there's a lot of pushback from some radiation oncologists about not wanting to enroll patients in a study that omits radiation, and that's understandable. They also have very narrow criteria for who can qualify for this surgery or for this trial. If you have a low tumor or more than limited nodal disease, you don't qualify for the study. But I think for the group of patients that do meet the criteria, that omission of radiation is something that's very promising, and we'll wait the results of this trial. And then the other flip side of that, which may also be part of why the other studies having trouble with accrual, is at the same time that we're trying to look at can you omit radiation, you also have other investigators looking at, well, can you just omit surgery? Do the radiation, skip the surgery? And this has been termed non-operative management or watchful waiting. The idea with the omission of surgery is based on the fact that it has been observed that anywhere from about 15 to 27% of patients who have neoadjuvant chemoradiation will have no viable tumor left at the time of their surgery. And so, in essence, they didn't need the surgery. The problem is identifying who those patients are that the chemoradiation has truly killed all of the tumor. The approach of the folks who are trying this is after completion of chemoradiation, patients have a thorough exam with imaging, endoscopy, physical exam. If there is absolutely no clinical evidence of tumor left, then the patients are just watched closely and they don't get surgery. If there is any clinical evidence of tumor, an ulcer, an enlarged lymph node, irregularity in the mucosa, if there's any evidence left that there might still be tumor, these patients do go on to the normal surgery. Those who do have a complete clinical response are then entered into very close surveillance. And this is very time-intensive surveillance. They are seen every 1 to 2 months with a physical exam and an endoscopy, and they are imaged every 6 months. So for a patient to want to do this, you have to be fairly motivated to not have surgery, because monthly visits for a physical exam becomes quite burdensome. But with this close surveillance and early catching of recurrences, these patients do appear to do well. One of the confusing things about this approach that has been controversial is that the data for how well it works are all over the place. The largest studies come out of Brazil. The very initial study was published in 2004. It described the experience with 265 patients who received standard neoadjuvant chemoradiation. 27% of them had a complete clinical response and so did not go on to surgery. On that initial group of patients, the authors reported a distant failure rate of 3% and a local recurrence rate of 2%. Those are amazing numbers that have never been able to be repeated. And so this really brought this into question. Some of these patients were probably T1 and T tumors that wouldn't have been treated with neoadjuvant chemoradiation in other settings, maybe part of why these numbers look so good. That same group published a different study more recently looking at 70 patients who received both the neoadjuvant, forgive the typo, chemoradiation, as well as their systemic chemotherapy up front prior to surgery. In these patients, they found almost a 70% clinical complete response rate. And subsequently, they've only had a 6% distant failure rate and a 25% local failure rate. These numbers seem much more realistic than those from their prior study and are encouraging. Of note, of the 25% of patients who had a local failure, all of them went on to repeat surgery except one. That one patient had a non-resectable recurrence. And so that's obviously worst case scenario, is that you don't do the surgery up front and then the patient recurs and now you've lost your opportunity for surgery and curative intent. And so that, while that is only one patient, that's certainly concerning. And it is the reason for the need for very close follow-up to these patients if you do omit surgery. So one of my trainees looked at omission of surgery because we had the sense that even though this is not the standard of care and really should just be done on trial at this point, that actually people were starting to adopt this approach in practice. And what he found is that from 1998 to 2010, the rate of omission of surgery basically doubled. While it's still not high, about 5% of patients are not getting surgery after their chemoradiation. And so we were interested in knowing who this is, thinking that this is probably the surgical innovators, and hopefully those people are on trial. But again, what we found is the people who aren't getting surgery are not the people you would expect to be getting surgical innovation. They are Black, uninsured, and Medicaid-insured patients who are treated at low-volume centers. And so while we're seeing a doubling of the omission of surgery, this is probably not due to the adoption of a novel technique in management of rectal cancer, but rather a worsening of an existing disparity in access to surgical care for rectal cancer. Looking at the same population, just slightly different years, 2004 to 2008, these patients who did not have surgery, who did not initially have surgery, also had a much higher risk of death, hazard ratio of death of 1.7. So this is certainly concerning. Our hope is to look into this further. We would like to actually identify these specific patients that aren't having surgery and do some qualitative studies to figure out what are the barriers to surgery. Are they aware that they should have had surgery? Were there financial barriers? Are they not able to access a surgeon because of their payer? Were they scared off at the thought of an ostomy? Or their cultural barriers? And so this is a study that we're working on putting together right now. But I guess one last thing to say about this is the poorer survival really emphasizes, though, how it's going to be important that if patients are treated non-operatively, that we carefully select which patients those are. And so just to wrap up, I want to say that there are many promising new treatment paradigms for rectal cancer. Some of our changes in sequencing and trying to tailor the care to the specific patient will hopefully minimize the morbidity of the treatments for rectal cancer without necessarily compromising the oncologic outcomes. But currently, the standard of care really has not changed. And that's why I spent a lot of time on the standard of care at the beginning, because it's important, as the final bullet here says, that as these new treatment paradigms are adopted, it's really critical that they be applied only to the appropriate patient populations. And so if transanal excision works for very early T1 cancers, that doesn't mean it's acceptable treatment for T3 cancers. Or if surgery can be safely omitted in patients who have a complete pathologic response to chemoradiation, that doesn't mean that, well, if they have a mostly complete pathologic response, that you can omit surgery as well. And so it's going to be very important that we, as the experts in the field, really communicate who qualifies for these different treatment paradigms, and that people pay attention to that when they're trying to select the best therapy for patients. So thank you for your time. Happy to entertain any questions.
All right. Thank you so much. Just a reminder for anyone who would like to go ahead and submit questions, you can go ahead and do that. You'll have the number 22333 that you're going to text to. If you already did that at the beginning, then you're all set, and you can go ahead and text your questions right to us. If you didn't, go ahead and do that now, the number 22333 with the letters UNCCN. You only need to do that once today, and then you can go ahead and start sending us your questions. So we'll take a look at that poll and see what comes up. And while we're waiting, I know that this discussion was really focused on treatment, but is there anything that you'd care to mention in terms of advances in diagnostics?
Well, that's another whole area, certainly, in colorectal cancer. I think what I will say, actually, which is not what you're asking, but I'll mention it since you asked. There's been a lot of press recently about rising colorectal cancer rates in younger adults. We've made tremendous progress in colorectal cancer. The incidence of colorectal cancer in those 50 and older has come down dramatically over the last few decades because of good screening. Screening, there is a colorectal roundtable going on in North Carolina right now focused on getting even more people screened, because it has been proven to decrease the incidence and improve survival, and it's working.
Great.
Which screening test? There are actually several screening tests that are acceptable, and it's really important that patients talk to their own provider about what's best for them. Colonoscopy is great, but the FIT test and some of the other tests that are less invasive are also equally good screening tests. Switching back to what I started on, though, is the press about those with younger. We have seen a doubling of the rate of colorectal cancer in patients under the age of 50. However, it's really important to know that those patients, it's still a relatively rare event. So while the relative increase has been a doubling, the actual number of people that impacts is very small. And so it's an important area of study, because we don't want the rate to continue to be doubling every 10 years. But at this point, the likelihood of getting colon and rectal cancer in your 20s and 30s is still quite low.
Good. All right. Well, thank you. And I see we've got a question that's come in. How can patients know which treatment best suits their diagnosis?
So I think for rectal cancer in particular, it's important to have a multidisciplinary evaluation. Similar, I would say, to breast cancer. Because many patients need chemotherapy, radiation therapy, and surgery, having an evaluation by all three of those providers prior to starting any treatment can help patients become informed about what the options are. It's very reassuring when you meet with all three of those providers and they all say, yes, we all agree you should do these same steps. But if you go to the surgeon and they suggest surgery up front, they go to radiation oncologist, they suggest something else, then it's important to hear those different opinions and decide what's best for you. I always encourage patients, when they ask me in my practice if they should get a second opinion, I say yes, as long as it doesn't incredibly delay their treatment, because these are important decisions that patients have to live with for the rest of their life, right? If you're going to get an ostomy, there's no undoing that later. And so taking the time to make the right decision for you is important. People get a cancer diagnosis and they want to rush into the first thing that's offered to them, and doing the wrong thing fast as opposed to the right thing at the right time won't necessarily pay off in the end. So it does need to be a discussion, and I do encourage patients to ask lots of questions, not only about just, how long is my surgery going to take, but what are the lifelong implications of these different treatments?
Yeah. All right. Thank you. More questions, please go ahead and text those to us. You can also email those to unccn@unc.edu. We can take them there as well. We'll wait a few more minutes for questions to come in. I know early on in the discussion you talked about neoadjuvant radiation and how that's and the benefits of that. How commonplace is that, and how much of a shift has been made?
That shift has happened. So it's interesting in the U.S. I spend a lot of time studying patterns of care in the research side of my practice, and one of the things about the U.S. healthcare system is that things can't be mandated very well, right? There are often suggestions, and so neoadjuvant, encouraging people to switch to neoadjuvant therapy is on guidelines, and it was pushed, and that actually is one thing that we did really well. People shifted very quickly. So we're doing a good job of that. There will always be some patients who can't get the radiation until after surgery because we didn't know that they would need radiation. We thought pre-surgery that they were stage 1 folks who weren't going to need radiation, and then they're the people with those occult nodal metastases. We find out later, you really do have nodes, we really should do radiation. And so there will always be some patients getting adjuvant radiation.
Okay. All right, thank you. Another question's come in from one of our listeners.
So we have been participating in the Prospect trial, and yes is the answer to that. I think there are a couple places in the state that are participating, but we have been participating as well, and so I think it's a very exciting trial myself. Happy to talk more about that offline if somebody has a patient they're interested in sending.
All right. You mentioned peripheral neuropathy being the primary side effect with chemotherapy, and I think specifically oxaliplatin. I know the FDA recently released the approval of the hypothermia gloves and boots in association. I don't know if it was specifically with Taxol or other chemotherapies as well, but in association with chemotherapy to help avoid some of the peripheral neuropathy. Is that relevant? Do you know to the oxaliplatin?
So it's it has learned at UNC, the group that's mainly trying to tackle this right now and figure out how we at UNC are going to handle this is our breast cancer folks. And that is an active area of discussion. UNC is trying to figure out how to, really what has been shown to work, what do we, much like my talk, what do we know works and what is still investigational, and then also how do we provide those resources for patients, because they do require new resources that we haven't otherwise needed. But that topic is being tackled at UNC right now. I have not heard anybody talk about using them for the oxaliplatin, but I would surmise that if we get the program set up for our breast cancer patients, that it may translate over to our other patients.
Great, thank you. All right, we have just another minute or two left. If we have any other questions that you'd like to submit to us, again, through our Poll Everywhere mechanism, one time sending UNCCN to the number 22333 and then your questions. Let's see, anything else that I have written down? I think that's all that I had. Anything else that you care to mention in closing?
Just make sure I didn't miss anything.
Sure.
Certainly, I am happy to take other questions if they come up. I don't know if they have contact information.
Oh, here we go. They do. All right.
Yes, I'll answer that question in a second,
okay.
too. So I'm going to skip to the. Can everybody see these questions?
Yes, but I'll repeat those just in case. So
I'm going to skip to the one at the top here.
Okay. So is the takeaway that there isn't any new promising, or there aren't any new promising therapies, but rather the combination of existing therapies? Is that
so
what
that's
people
probably
should walk
true.
away with?
It's differencing in the sequencing and tailoring the treatment. So it's different treatment paradigms, but not actually a new whole new modality of treatment is not new. However, in general, for these colorectal cancers, we are doing well, and the systemic therapies, there are new systemic therapies for the stage 4, I guess is what I'm trying to get at. I just didn't tackle that whole area today. But for those patients who don't have metastatic disease, we haven't introduced anything new. We're just trying to tailor what we do to minimize the morbidity.
All right.
As for are there certain counties in the state where the disparities are most evident, the answer is absolutely yes. There are different pockets throughout the state. They tend to not be surprising. There are areas with less healthcare resources and less economic resources. There was an article published about 2 years ago now that looked at hotspots nationwide for high rates of colorectal cancer and poor survival from colorectal cancer. And they identified 3 areas in the nation, geographic areas, that had the worst outcomes from colorectal cancer. And one of those 3 areas involved 12 counties in northeastern North Carolina, as well as some counties in southeastern Virginia that are contiguous with that area. And UNC and others through the UCRF are working actively to try and tackle this. Dan Royland and Stephanie Wheeler, some folks in the School of Public Health who are taking on this in conjunction with the state North Carolina Colorectal Roundtable to try and figure out how we can get better screening and better access to care in these areas. But there are definitely disparities both in screening, which translates to differences in incidence, but also in survival and actually receipt of care.
I'll use this as a plug. If you haven't seen some of our earlier lectures, we have one in the last year with Dr. Wheeler and also another one that specifically addressed disparities in North Carolina and some of the effective interventions. So I certainly encourage our listeners, if you haven't seen either of those talks, to go back, look at our library, and find those because they were very good.
I haven't seen the talk, but she's fantastic. So
she certainly is. Let's see. Let's go ahead and a few remarks in closing. We want to thank the University Cancer Research Fund and the state of North Carolina for their generous support of that fund making this possible, and the UNC Lineberger Comprehensive Cancer Center. Additionally, want to thank Mary King, our operational coordinator, and Alan Brown, our continuing education specialist, for all the hard work they do to make each one of these presentations possible. We do have more lectures coming up, Community Lunch and Learn on March 31st, and When Treatment Fails, Supporting Loved Ones During End-of-Life Care. We have on April 12th an RN and Allied Health lecture, Oral Chemotherapy, Overcoming the Challenge to Adherence. And in addition to the CNE and ASRT credit, this lecture will also offer pharmacy credit from the Accreditation Council for Pharmacy Education. So if you know anyone any pharmacists who would like to attend, please spread the word. That's not something we typically do, but we are doing it on April 12th, and depending on how that works out, hoping to maybe explore doing that more frequently. April 26th, Medical and Surgical Oncology lecture, Managing Lung Cancer Heterogeneity. So we hope that you'll be able to attend all of those upcoming lectures. If you have any follow-up questions, you know where to find us, unccn@unc.edu. I mentioned our lecture library. That's at unccn.org. You'll find a library with over 150 different archived lectures, more every day. We're on YouTube. Or not every day, but every month, excuse me. We're on Facebook. We're on Twitter. You can find us on YouTube, lots of places to find us. Please spread the word, share information about these freely available lectures and the various types of, again, these are available for ASRT credit, for CNE credit, and today, and with the medical lectures for CME credit as well. All right, that concludes our lecture. Thank you all so much for attending. Thank you so much. This has been a great presentation. We really appreciate it.